Hello and welcome to Doc Talk Live. This is NorthBay Healthcare's way to reach out to the community on important health information. Today we are talking about dribbling, drooping, and drying up, the silent suffering of menopause. And with us is Dr. Shanna Snow. She's an OB-Gyn with NorthBay Healthcare. Dr. Snow, take it away.
Thank you so much, Robin. And thanks everybody for joining us. We appreciate it. We know tonight is a very important political night, and we just realized that, but if you're here, then we super appreciate your participation. The topic is one that I think is really important for my female population, and specifically my female population that's kind of heading into menopause or already in menopause, because people don't want to talk about it, and all of the issues that we're going to discuss tonight are very common. Almost 50% or more of people are going to experience at least one of them, and it just kind of seems like we're not supposed to mention them because we're females and we're supposed to keep things quiet, and I disagree with that. I think we need to talk about it, get it out in the open, and then address it if it's something that you want to fix. So the original title of this was actually Dribbling, Drooping, and Drying Up. Proper ladies do speak of these things, because I want you to bring it up. I want you to talk about it, and to get some ideas on how we can help you. So dribbling, if that doesn't immediately make sense for what we're talking about, we're talking about urinary leakage. There's several different types of urinary leakage that are out there, but up to 50% of women will experience urinary leakage at some point in their life. Some can start almost immediately after having children, and those little rascals are super adorable, but they wreak havoc on your pelvic floor, and so they cause some trouble. Other women may not experience it until after menopause, if ever, but it's a really common problem and some easy fixes that we can do. Some of the symptoms that women might have with incontinence or overactive bladder, which is slightly different, doesn't include leakage, but may just be that you feel like you always have to go all the time. Some people that have leakage of urine will experience it with a cough or a sneeze or a hearty laugh. And that's termed stress incontinence. If you have leakage that's more of a, as I get to the door, if I don't have an immediate access to the bathroom right then I might leak some urine. And then there's other types of incontinence where you can have a little bit of both, and rare types of incontinence where you have like the bladder fills up too high. But for the most part, stress incontinence and urgency incontinence, we call are the most common. With the stress incontinence, it's more of a physical issue because I have a little diagram here that I brought out to kind of show you what's happening. With the bladder sitting up here, this picture is hard to describe, but it's basically as if I cut somebody in half and I'm looking at you halfway through your body. So the front of your body's over here, back of the body's over here, your pubic bone is here. The bladder and the urethra, where the urine comes out, is in the front. Right behind that, you have your uterus overlying the vaginal canal. And then right behind that, you have your colon and rectum. And so with stress incontinence, this floor here where all these muscles are supposed to be nice and tight, either destroyed by those cute little tiny humans called childbirth or by various other things that happen over time, these muscles get really weakened. And when you cough or sneeze, this nice tight muscle here that holds the urethra can kind of bend and bow, and that allows urine to leak through. So that's the stress incontinence. Urgency incontinence has more to do with the muscle of the bladder itself, where it fires when it's not supposed to fire. And so you might get what we call detrusor muscle instability, and if it's active enough, it will squeeze so hard that you leak urine and you don't have any really control over it. The first thing to do if you're feeling like you're having any of these symptoms is to talk to your provider. It may be as simple as changing your diet, drinking less fluid so that you're not going in the middle of the night, performing a Kegel and tightening the muscles at the time of laughing or sneezing, or we can do some more tests to figure out if there's anything deeper going on. Simple office tests that we can do is checking the bladder for how much urine you can hold and whether or not any leaks with coughing and sneezing. And then we have really complicated tests that we can do looking at all the different muscle layers. Some things that you can do are changing your diet, avoiding drinking too close to bed if that's a problem. Some people have often issues with overactive bladder with irritating food, so pretty much the good foods, the caffeine,
Please don't say chocolate. Please don't say chocolate.
Chocolate, spicy foods, various other citrus and acidic foods can cause it, so we might be able to alter with that. Weight loss can sometimes be a factor if weight is contributing to some bowing and pressure on those pelvic muscles, but isn't always the source. Just avoiding constipation can sometimes change the whole pelvic floor musculature, so really easy stuff that you can do. Other things that you can do are call us and we can talk to you about them. So Kegel exercises are simple and you can find lots of different guidelines online for how to perform those. One of the methods that I've heard is to imagine that you're sitting on a marble and you're trying to pick it up with your vaginal canal. So if that helps you, you can use that. Other people I've heard say, try to imagine that you're in the middle of peeing and somebody walks in on you and you have to stop your stream immediately and get out of the view. So that's another way. But we do have pelvic floor physical therapists for people that are struggling to figure out that exact motion that they're trying to use that can come in and really show you how to perfect it, and other techniques you can do to strengthen those muscles and get everything back up to par. And 60-70% of the time that can help you alone. If that's not enough, we have medications we can consider. Pessaries are little devices that go in and sit vaginally in this area here. They're like little donuts, and what they do is push some support on the bladder, so they hold it and support it up, and you just leave them in during the day and take them out at night or over the weekend. Very simple little things that we can do, all the way up to surgical procedures where we put tiny bits of tape / mesh underneath the urethra so that it doesn't move when we need to. For urgency symptoms, medications are often used, and if the side effects can be bad in some people, but if they're otherwise tolerated, then they work really well. So really simple things we can do to get your life back so that you're not worrying about this coughing and sneezing and running to the bathroom at all hours of the day when you should be enjoying your life. Along the same lines as dribbling is drooping. And with drooping, what I mean is the organs falling down. And so back to that picture that we talked about before, when you have a normal anatomy, everything is kind of sitting up in the body the way it's supposed to. But with time, these muscles and layers in between everything get weak, and the muscle floor down here does. And so your bladder can actually start to fall down, and it pushes into the vaginal canal and can even come out all the way vaginally. Same thing with the uterus. It can kind of start to slip down and you start to see the uterus poking out at the bottom of the vaginal opening. Same thing with the rectum. Can push in, and sometimes as you're trying to have a bowel movement, you actually have to push on inside vaginally and push it down so that it goes out the right way. And all of these things are caused by the same issue of muscle laxity and destruction of muscles through various things that happen to us poor women as we age. Some of the symptoms, so a lot of people will have no symptoms or just a little bit of fullness or pressure, and generally if those are your only symptoms and they're not bothersome, I will leave you alone. I have no reason to cause you any more issues if it's not bothering you. But some women will progress to having pain or a bulge that they can feel come out, or discomfort when they're trying to sit. And in that case, it makes more sense that we consider some techniques to help you so that you're not always experiencing that discomfort. Easy things that we can do for diagnosis is to just have you come into the office. We take a look, we can see right off the bat what's going on, take some measurements. If we need any more definitive measurements, we might consider a pelvic ultrasound, but very minimally invasive things. Once we make the diagnosis, again, we may say, it's not really bothering you, you're good, we'll leave you alone. But if it's bothering you, we could go back to those Kegels, strengthening that pelvic floor, sending you to a physical therapist that can really show you how to hone in on those muscles and get them back up where they used to be, can be very useful. The pessaries that we talked about work in this area as well. They slide in vaginally and they kind of hold everything in the place that they used to be. And if those aren't enough, or you just don't want to deal with something in and out and having to think about it, then we can move on to surgical options. You hear a lot nowadays about mesh and how harmful that was and some dangerous things that it did to women. So we know that now. We tried a technique over years and years that wasn't very successful and had complications. So we've removed it from the market, but there are still lots of other techniques that we can use surgically to help people to address that if we get to there. But surgery is definitely our last case resort. One final thing I want to mention about mesh, in case there's anybody out there that's had problems with this, are we're finding issues with people that had full vaginal mesh placements that are having pain after menopause and unable to initiate intercourse. And we just want to let you know that we have methods that we can help with that, and there are specialists that are even in our area that can help with that I've sent people to recently. So if you're having any of those issues, please come see one of us at the Center for Women's Health and let us figure out what we can do to get your life back. Final thing I wanted to talk about is drying up, which is exactly what it sounds like. So after menopause, all of those hormones that keep everything nice and lubricated and tend to drop off with our ovaries slowing down. Average age of menopause is 51, but perimenopause is the time that you start experiencing those symptoms, and that can start years and years earlier and can persist for years after the actual time that you stop having periods. I have a picture I wanted to show here just to kind of show people a little bit of the anatomy, and I didn't want to have like a real life picture because I thought that might be a little bit too intense for a video. So I got this cartoon one, but I think you get the idea. This is the idea is as if you're in stirrups and we're taking a look and we're looking directly into the vulvar vaginal area. So vagina is the thing that we all know about, the whole opening and where babies come out and how we have penetrative intercourse, but there's many other structures around that. So the opening to the vaginal canal connects into your labia. Your labia minora are the ones that are immediately next to the vaginal canal. And then you have your labia majora that are more of the covering, so they tend to kind of come together when your legs are closed and protect everything. Then outside of the vaginal opening, you have your urethral opening. I have had many patients, it's not uncommon to think that those are the same opening, but they're actually separated by a band of tissue. And then the clitoris is above the urethral opening and has some protective layers around it as well. And then this picture does not show it, but of course your rectal opening or the anus is down here. So, we've got 3 different areas that we have to think about that can have effects from menopause. One of the things that you might experience if you're having these effects is vaginal dryness or burning, especially with urination. Burning if you're feeling like you have to pee all the time is different, but if you feel fine and then when you urinate it burns, it could be because that tissue has become dry and what we call atrophic, and you need to be evaluated so that we can figure out if there's anything we need to do to help. Some people will experience less lubrication during intercourse, and that can be frustrating and painful. They might even bleed during intercourse. Some people will have a vaginal discharge, and that could be a sign of infection that we might want to treat that is more common after menopause. But it also could be just a sign of, menopausal changes in the dryness, and so we want to evaluate that. And then, of course, the urinary problems, that we already addressed can happen as well. There's studies that show that 85% of women after in perimenopausal years, so 40 plus, will have some consequence of this dryness, and up to 60% will have painful intercourse. So it's a big deal. It's a huge thing that affects quality of life. Figuring out what it is really simple. Again, an exam, maybe some vaginal swabs in the office, but nothing too crazy that you have to worry about coming in to see us for. Some things that you can do to help would be moisturizers that you can place vaginally. That coconut oil is a simple one, vitamin E. There's also brand name ones like Replens and Silky that you can get and spend lots of money if you so choose. During intercourse, using lubricants, especially silicone based, that can help you to reduce the amount of friction, can be very beneficial, and super simple things. Some things that we can do to help would be medications, vaginal creams, estrogen and hormone therapies, although we do have non-hormonal techniques that we can use as well. And what those do is increase the amount of estrogen, which increases the elasticity and the lubrication, again, to the vaginal canal that tends to drop after menopause. There are also oral pills that you can take if placing something in that area is just not something you're interested in. So we talk about all those different options and risks and benefits that come with everything. More experimental therapies are out there, like vaginal laser therapy. We don't have enough information yet to really recommend them, but I've definitely had patients that have tried them and it's worked. And so, come see us. Let us know if you're having one of these issues, and we can address it and get you feeling better, get the dryness resolved, and potentially get you back your sexual activity if that's something that is of interest to you, for sure. That's everything that I had to talk about. So
we are getting a few questions here, and just for those who are tuning in, if you have a question, that's just like any other Facebook post. You click on the comment button and type it in. We'll be able to see it and pass it along to Dr. Snow. We have two questions, one posted by Sarah and one by Sonia, and thank you both for posting your questions. They're kind of related. Sarah asks, how young do you start to have hot flashes? And Sonia knows, do the hot flashes ever stop?
Those are both very good common questions. So generally, average age of menopause is 51, but we may start getting menopause as early as age 40, and it's not abnormal. And then that perimenopause, the leading into the actual cessation of periods, which is what we call menopause clinically, can be years before that. And so it's not uncommon for some people to start getting hot flashes in their mid to late 30s, all the way up to some people don't start their perimenopausal journey until, age 52. So there's a huge range. Every woman is different as far as their longevity of how it lasts too. I've had women that never get it at all, some that last 6 months and they move on. I tell them to be a little quiet in the waiting room because I don't want them to get beat up, because then there's other women that, it's lifelong, and they start in the perimenopausal period and go all the way until their 70s, 80s. But the idea is that everybody's different. It can be normal, but we want to evaluate it. And if it's bothersome, we want to treat it. But we don't have to treat it if it's not interfering with your life.
Okay. So how is a person supposed to know if what they're experiencing is menopause or some other health issue that's going on? Absolutely.
Yeah, that can be confusing. One of the things is age, for sure. So if you're around the average age of menopause, so I would say probably 45 to 55, and you're experiencing these symptoms, It's not rocket science. 99.999% of the time, it's probably perimenopausal symptoms. If you were outside of that age range, it very well may be normal, but we would want to evaluate and take a look and just make sure that we're not missing anything. If you had experienced menopause and had symptoms and then they went away for a long period of time and then came back, again, that could be normal depending on lifestyle changes and things, but we would want to evaluate you at that point and just make sure we're not missing anything.
You mentioned in your comments that if interested in intercourse after menopause, can you talk a little bit about how to increase that libido if it has completely disappeared?
Absolutely. So that is a extremely common question, unfortunately. And, I do like to start out my counseling on patients in the office that it's not uncommon for women's libidos to drop near menopause, after menopause, and for your partner, especially if your partner is male, to not drop. And that unfortunately, is a sign that males and females, depending on your hormones, can be different and can be impacted as we age. But it doesn't mean that that's what you have to live with. It's just something that can be normal. And if it doesn't bother you and you don't want to have sex anymore, you don't have to. We can talk about different ways that you can invite intimacy into your life and still, have a good relationship with your partner without having specific penetrative intercourse. The second thing that I like to talk about is that we have to fix for the female brain, hormone regulated brain specifically, we need to fix certain things before you're going to want to have sex and have libido. So if you're having pain, you're not going to want to have sex. If you're stressed out and you've got kids that you're taking care of and your partner is not participating in any of those activities, that may be another reason that you're not interested. So we want to address all those components too. If we've ruled out that there's nothing else and really it's just a physical hormonal situation, then we have some different things that we can do. Testosterone is a newer treatment that's been around for years, but it's just been agreed upon by the College of OB-Gyn that it is safe and effective. We do have to watch it and monitor it, but we can use testosterone to help boost that libido. Outside of that, in the perimenopausal or off-label in the postmenopausal, we have specific medications that go after the brain chemistry to increase some of those chemicals that drop after menopause when the hormones kind of drag them down. And we can go after those specifically to help to address the libido issue. So we definitely have things we can do. If it's something that's interfering with your life, come see us and we can talk about all the options.
Okay. Shelley asks, I'm perimenopausal. I miss anywhere from 4 to 6 cycles and then I have them again. I'm going to be 47 years old. Would you call me in the middle of perimenopause?
I would love to give you an exact timeline, but unfortunately there's no way to know that, and we don't even really have labs that can tell us where you are in the process. Clinically, we say you are definitely in menopause when you have not had a period for 12 straight months, and then you shouldn't see a period again after that. And if you do, it's termed postmenopausal bleeding, and we need to address that to make sure we're not missing something catastrophic like cancer, even though that's rare. But how long where you are in the process, how long this is going to go on, the only thing I can give you is that the average age of menopause is 51. And so you're probably in the middle of it, but you might be, going through menopause at age 48, so you're getting closer. One thing you can do, it's not an exact science, but you can talk to your family members who you may run into the same frequency of if they went into menopause at age 48, then more people in their family might go into menopause around age 48. But again, it's not an exact science.
Okay, we have a question from Lynn. It looks like it cut off, but we have most of it here. So, OTC vaginal moisture replenishers are uncomfortable to use because of the applicator. What alternatives do you suggest? It seems to help at night with nighttime urination, but ? So perhaps you can address that whole issue.
Yeah. So over-the-counter vaginal moisturizers can be uncomfortable because of those applicators, and some of them are not well built or they have seams. You want to avoid those. So I will tell you, a very easy applicator is this right here. There's no reason that this can't be placed vaginally. And so you can take those same creams, if they're otherwise working well, place them in the palm of your hand, do this and get a nice amount on, place it vaginally, get it all as high as you can. And then if you have any left, you can do it 2 or 3 more times. Some people, I really recommend, instead of spending all this extra money on over-the-counter moisturizers, just coconut oil. You can go and buy a big old vat of it for really cheap. Place it in your palm, move it around a little bit till it turns into a liquid, or you can get the fractionated kind that's already liquid, place it vaginally, and just like you moisturize your face every day, you can moisturize that area as well every night before you go to bed.
Nice. What about ovulation after menopause? Is it possible?
So theoretically, anything is possible because we don't always know 100% if you're in menopause. There are other reasons that you could not be having periods. So we always want to evaluate, especially if you're not in that age range that we expect, before we say you are golden, you don't have to worry about pregnancy. If you're after the age of 51 and you've stopped having periods for 12 months, we're going to say, yep, that's statistically what's going on. You don't have to worry about it. But less than that, I would say you always want to check with us and, let's just make 100% sure that we have the diagnosis of being in menopause before we say you're good to come off that birth control. You don't have to worry about those accidents, because everybody in my office, I'm sure, has seen one or a handful of pregnancies we weren't expecting. So we always want to be sure.
Okay. Regarding hormone therapy, what do you usually say to your patients in determining whether or not they need to start going on hormones?
So the guidelines for us from the College of OB-Gyn say it is symptom relief only. We used to prescribe medications because we thought there was some long-term benefit, decreased heart disease risk. We know that there is some benefit with osteoporosis, but there are other ways that we can treat that specifically. So our treatment is based on your symptoms and your quality of life and how you would want to address those. And then we go with the lowest, most safest route of hormones, the lowest dose and lowest duration that we can use to get you symptom relief. And we move up from there until we get you to the point that you're happy. There's no exact time that you have to stop postmenopausal hormone therapy. I have some women that, after a couple years, they don't need it anymore. And I have some women that are 20, 30 years out. The risks potentially increase for using it that far out, but we're always looking at quality of life as well. And so I'm never going to take it away from somebody. In fact, I've had some women in their 70s and 80s that might stab me if I tried to take away their meds, so I would never do that. But I really try to look at the patient individually, counsel them, and then include them in the counseling. And if you understand the risks and benefits and your quality of life is improved, we can keep going.
Are there over-the-counter options for dealing with hot flashes?
It's a good question. There's not a lot of well-done studies that show that, but some soy products have been shown to be beneficial because they mimic estrogen in the body, and so soy products and supplements that are whittled down soy can help. Black cohosh, specifically by the College of OB-Gyn, has not been shown to be beneficial. However, I've had many patients talk about the brand Remifemin that seem to help them. And so we always want to counsel that over-the-counter medications that theoretically raise your estrogen levels can have side effects and potential risks as well. So talk to us about using those, but we do have options. And non-hormonally, acupuncture, exercise, weight loss, alcohol reduction or cessation, tobacco cessation. There's lots of other lifestyle changes that can help with menopausal symptoms before we get to commercial meds.
So the bottom line is they don't have to suffer in silence, right?
The absolute bottom line is there is no need to suffer. We have lots of simple treatments. Talk about it. Talk to us about it. These aren't taboo topics. These are normal topics we hear about every day, and we have lots of tools in the tool belt to help you to get you some symptom relief and make you feel better if you need that. And if you don't want us to bother you at all because you're living with it and it's not interfering with your life, we will leave you alone.
All right, if you don't want Dr. Snow to leave you alone and you would like to get a hold of her, you can reach her at her office number, which is 646-4100. We're out of time, but just a reminder that this Thursday at 10 a.m., that's October 1st at 10 a.m., we will have another one of our COVID chats with Chief Medical Officer Seth Kaufman. So with that, thank you, Dr. Snow, for taking time. We appreciate it, and thank you to all of you who tuned in.
Good night.